Welcome back to this week's episode of Promising Young Surgeon. I'm your host, Dr. Frances May Hardin, and today we are stepping into the world of tech innovation. I am beyond excited to have Nithya Ruff here with me today. Nithya is a true trailblazer in a historically male-dominated industry. And today we're going to dive into her inspiring career, her approach to innovation and leadership, and invaluable advice for women in male-dominated professions. I'd love to introduce our guest. Nithya Ruff is the head of open source software at Amazon, where she and her team ensure that Amazon's engineers can leverage open source software to create top-notch experiences and services for customers without introducing new risks. Behind Amazon services are thousands of developers dedicated to innovative software development, and Nithya plays a crucial role in guiding the open source journey. With decades of experience in the technology sector, Nithya has witnessed the evolution of tech from mainframes to artificial intelligence. She remains constantly inspired by the potential of technology to enhance human life. She has also observed the significant advancements in diversity, equity, and inclusion and workplace environments, progressing from industrial age setups to more evolved and inclusive spaces. On a personal note, Nithya's journey is just as remarkable. Arriving in the U.S. as a foreign student, she defied familial expectations to marry a German-American fellow student she met in college, and their union has thrived for 40 years. She is the proud mother of two accomplished daughters. One is in her family medicine residency, and the other is an Emmy Award-winning journalist and digital marketing expert. Supporting their happiness and success, built on her own life lessons, brings her immense joy. And then, of course, we have a couple fun facts, which we always love to share. Nithya is focused on her legacy and her impact. She has embarked on two major passion projects. The first is a cookbook, where she's working on a book of legacy recipes for her family, preserving cherished recipes that otherwise might be forgotten. And then also a book on her journey. She's writing a book about her experience as a woman of color in the tech industry, spanning from the 1980s to today. This unique perspective will be shared in her upcoming book, set to be published within the next 2 years. Nithya, thank you so much for joining me today.
Dr. Hardin, Frances May, so good to be here. Thank you for having me.
Oh my gosh. And I just I love reading about your whole life and career. I love reading your fun facts. I am so impressed by you always. And it's no small feat to raise two daughters in the successful industries that they're in now.
Absolutely. And that's one of the proudest accomplishments, I would say.
Absolutely. Well, and of course, I'm excited to dive right into it. And I would love if you could kind of share with our listeners, how you got connected with Promising Young Surgeon and why you are, honoring us by joining a podcast that has been aimed so much at the physician audience and, physician community.
Frances May, I am the mother of a medical student and then now a resident. And so I was looking for how can I support her in her journey because her world was so different than mine in tech. But yet it seemed very daunting and challenging. And as a mother, I was trying to look for resources and also educating myself on the world of medicine. And that's how I stumbled upon Promising Young Surgeon and reimagining residency as well. And it really impressed me that someone was advocating for residents for an improved experience, if you will, for education in medicine, and also was providing resources and education on how this industry works, how to, influence it, how to make difference in this industry. Frankly, that has allowed me to support my daughter so much better and understand her world so much better. And I'm an avid listener to your podcast and an avid commenter on your podcast because there's so many important discussions on your podcast. So thank you for that.
Well, that's seriously so kind. You're going to make me tear up. Because it means a lot. And especially, again, this is coming from somebody who's so brilliant, has had a very long career in a different traditionally male dominated industry. And, I appreciate that some of our conversations, which again, we'll get into today, but some of our conversations in the past have really highlighted similarities and differences between tech and healthcare, ways that we can learn from where tech has succeeded at creating more inclusive, psychologically safe environments. But I appreciate you sharing that as well, because I do want to just highlight the fact that, yes, I'm always trying to create resources for physicians, the next generation of physicians, and also those of us who maybe are, into our career, who are trying to heal from some of the past training and, practice experiences. But what has been, I think, really very moving and maybe unexpected for me has been outreach from loved ones and family members of physicians, where they themselves, are not in medicine. And yes, they're trying to make sense of, sometimes it's scary. Like, okay, well, my loved one, my partner, child is behaving maybe differently. They seem withdrawn. I've had people reach out to me with these types of concerns, and it's always very moving to see loved ones care enough to look for resources or say, wow, they're not sharing with me. I can see that their work environment is a little different from anything I've ever experienced. I just think that in and of itself means a lot, but it also, I can say, from my own experience, like, it is really hard if you love someone and they're going through it and you don't totally understand what they're going through. I think probably a lot of us can speak to that. I've certainly experienced it. And it's like, you love them, you want to be there for them, but it's so hard to be there for someone when you don't know what it's like to walk in their shoes.
Absolutely. And I kept looking for parallels between, my lessons learned and what helped me in my journey as a woman in tech. And how can I then share that knowledge with her? And that's how you and I got talking.
Exactly. Well, just to provide some context for all of us, the work that you do is incredible. I am not extremely literate in tech, so it sounds very fancy, like very intimidating. And I would love if you could just open by explaining to us kind of open source broadly this work that you've done and innovated in, just so that we can know what you've been building in your career.
Absolutely. So software is typically in the old days, say prior to the 80s, it used to be built by companies, and they would give you an executable software for a price, and you would then run it based on a license. What the open source software movement did in the 90s is they said, why can't we empower a user to actually look at the source code of the software, modify it if they want to, change it, add to it, and then redistribute the software. So that completely changed the face of how software was developed, because now everybody, users as well as people around the world, could actually contribute to the software and keep growing it. So today, and it's free. It's freely available. It sits on a collaborative platform called GitHub, and developers from around the world can actually look at the software. And if they see some problems with the software, they can fix it. They can actually change it. What this does is it makes a lot of software available for companies to use. So companies are no longer just creating their own software. They are actually using open source software to create experiences. So, for example, if we are creating a device like Alexa or Kindle, we not only create Amazon software, but we also leverage existing open source software that's already solved problems for building devices or for sound or for AI or for other components. And then we assemble all of this together, and then we provide this as a unified experience for customers. And so open source software has become very, very important to the world of software, and for companies to know how to consume it, how to contribute to it, how to be part of this global ecosystem of developers. I hope I explained it. It's a hard concept to explain sometimes.
No, that's so cool. I really appreciate it. I feel like that helped me to understand it a lot. Although, I'm sitting here and I'm listening to this like really incredible resource platform. And what's funny is in my way more limited tech experience, I'm a surgeon who works on an EMR, and a lot of us are constantly fighting with the electronic medical record or EMR. And it's just funny because we're so siloed. Even a lot of the current, AI and digital health, like those programs seem just so siloed. And for instance, I practice in a rural area, and we deal with a lot of the fact that we can't see images or access records from even 60 miles away. So it's just funny because to me, you're talking about the year 3000. I'm like, wow, why and why not? And when can we, apply this to what we interface with?
Healthcare is one of the most traditional industries from a tech perspective, and we haven't seen too much open source innovation in the healthcare industry. Though during COVID, we did see some free apps being made available for testing or for tracking, the spread of COVID and things of that nature. But aside from that, I think I agree with you. I think users should have more power to examine their software, to be able to change their software, to be able to work with others and interoperate across, different software silos.
Yeah.
Surprising you mentioned healthcare. This is an area I think that's ripe for disruption, from an open source software perspective.
That's very interesting. Well, wonderful. I mean, I'd love to kind of dig deeper into that another time because it's very interesting. So I appreciate you explaining that to us. And then next, if we could move into, from the 1980s up to present, what working in tech, again, historically male-dominated field, has meant for you, and kind of, the overview of that journey and what lessons it's presented.
Absolutely. When I started my computer science journey in the 80s, there were quite a few students, actually, women students in our master's program in computer science. But then over the years, the number of women entering computer science and engineering, really dipped down. And then it's starting to go up again. And in the workplace as well, women were often, when I started my journey, one or two engineers in a group, in a big, large team of multiple engineers. And so you often felt like you didn't belong, and that people were speaking a different language than you. I would be intimidated to ask questions. It was very cliquey in many ways. The guys often hung out together. And so breaking in and actually being respected, being heard was difficult in the 80s and 90s. And I must also say that diversity and inclusion as a whole was still evolving in those days. So you didn't have much of a vocabulary to use in terms of why diversity is important, why inclusion is important, how to be an ally, how to onboard people into a team, etc. And so the 80s, I feel, were pretty tough in terms of just getting through. In the 90s, I would say it was a little more mature, and you started seeing, more women in teams. You started seeing managers being trained on diversity and inclusion, understanding why teams need to be, an inclusive team, why we need to welcome everybody into the team, the positive effects on customers if you have a diverse group of software developers developing software, because the consumer world is made up of half and half, and different kinds of people. So we do need to understand what customers need, and having a diverse team really reflects and brings together diverse opinions into work. You've often heard of examples of seatbelts being tested only on male dummies, right? And There are so many other examples where not having a diverse team made the product very restrictive or not complete or not inclusive or accessible from a customer perspective. I would say the real breakthrough from feeling included and feeling like I was a significant player in my team was in the 2000s and 2010 and 20 on. You started seeing a much more mature vocabulary around diversity in companies, the concept of allies, the concept of sponsors, the concept of mentors, the concept of employee resource groups, why having a women's group in the company was important, or Black employees or Hispanic employees, that you needed to provide a safe space for these groups to actually work together and to play together. So I would say that's when I feel it's been really impactful and a better place to work. Today, one of the things that we measure as managers in Amazon is how inclusive we are, how we are bringing in a diverse team, how we are encouraging, mentoring, promoting, supporting women as well as men in the team. So I think it's by aligning incentives for managers to manage these important outcomes is how you get to better outcomes.
And I love that you made that point at the end, because that's really exactly what I was thinking. Like, as you walk us through your journey, several things stand out. Number one, that this did not happen in tech overnight. I mean, legitimately, even your experience in tech, your career has spanned decades. And while we can examine multiple of these shift points or, transition points, I think of how in the 90s, there was maybe a little bit more education, training, introduction of awareness and vocabulary. And I mean, maybe that took 10 years to really start to play out in a meaningful way for people. I think that that's kind of what's interesting. And I almost question if maybe we in medical training, surgical training cultures, healthcare, maybe we're at the point, and this is just my personal opinion. I mean, obviously I don't, all I can do is give my impression, which is that I think we are starting to have maybe some vocabulary for these things, but I don't feel like we're at the tipping point where now there's buy-in at a lot of different levels, or where even the majority perhaps are acting on it in a way that the trainee or the person who's experiencing it is having a meaningfully different experience. I mean, it may be, and it's a long journey. So maybe people are starting to feel those cascading effects, but certainly tech is ahead of us. So it's interesting. It's nice to kind of like look at that timeline and say, okay, well, I guess we're on the journey. Where are we? Maybe not as far as we'd like to be, because I want to be with you guys, I think, in that regard.
I think tech is ahead of a lot of industries, and they've had to be ahead because of competitive reasons, because they started seeing the benefits of having a diverse pool of creators and makers, if you will, serving customers. And I'll also say having more women, more diverse people in leadership makes a huge, huge difference, because policies start changing. Being at the table helps you express your voice in terms of what's needed.
Absolutely. And what I think is important, though, is, so one, like you said, tech had to advance. It had to get with the program to probably recruit and then maintain incredible talent and things like that. What's interesting at the graduate medical education level is this, kind of unusual system, right? Like this unusual setup, unusual system where there's competing interests. Like at the end of the day, residency programs, even fellowship programs, often when they're training someone, they aren't thinking, okay, this is going to be, a long-term employee and team member for us. We are trying to, make this an incredible investment and experience for the person. That's not really how that revolving door has been traditionally for us. And I think that plays out in a lot of ways. As opposed to how you were talking about, like the managers, they did have to buy in to an extent because every manager wants to have a great team. We don't see some of those more traditional even structures on the healthcare side. Like, you don't always experience that as a physician. One thing that it's so funny because I just pulled this up, I'd love to get your opinion. I don't want to, I've been up since 5 a.m. today, dealing with some nosebleeds in the emergency room. So I just want to tell everyone, if I sound ornery, like, it might be that, it might be this though, because I want to share an article with you. When we talk about that point along the journey where people start to have some vocabulary for things, but maybe there's not buy-in at every level yet, especially at the higher ups, I think of this article. It's from the New England Journal of Medicine, published in 2024. And it's entitled, Being Well While Doing Well, Distinguishing Necessary from Unnecessary Discomfort in Training. And it's written by Lisa Rosenbaum, MD. And, it's a very interesting think piece that's from almost the antithetic perspective as the podcast Promising Young Surgeon. It's from a lifetime academician, also very interestingly written by the child of a nationally prominent physician, about tensions in the workplace, about what constitutes a toxic culture or not. So I recommend this think piece to anyone who hasn't seen it. I do think that it probably lives behind a paywall. If we can link it directly, we'll ask our producer to do that. But I'll read you, how about this quote? If everything is trauma, is anything? As language is similarly weaponized within medicine, we must grapple with the resulting trivialization of problems that deserve more urgent and sustained attention. Experiencing daily racism, for instance, is difficult from being asked by your patients if you're old enough to be a doctor. Having to admit a new patient right before end of shift is not a moral injury, and burnout is not the same as depression. I think that kind of remarks like saying having to admit a new patient right before end of shift is not a moral injury, that's a little bit like, I'm not sure anyone is saying that that's moral injury. Are you shadow boxing with yourself? I'd love to know any of your thoughts about this article. And I know I'm just bringing this up really spur of the moment, because I just think that, of course, there's going to be two sides of the debate. As things like psychological safety come up in the workplace, there's a whole, and in my experience, 50% of people, if not more, are saying, well, do we even have a right to psychological safety in the workplace? I didn't have it. And, it's not really up to me if you are a nervous cat and you don't feel psychologically safe in the workplace. We're in the midst of, I think, a lot of that debate in medicine.
It just seems to me, from a medicine perspective, this is an outsider looking in, patient care and the fact that it's life and death are so important that everything else is put aside. Doctor health, team health, the well-being of trainees, etc., all seems to be sacrificed at the altar, so to speak, of patient care being the most important. And I don't want to debate that patient care is not important, but I think it can be balanced with a healthy team, a healthy, training, etc. It feels like patient care, as well as the cost of healthcare and the litigious nature of healthcare, seems to kind of dominate the dialogue. to the extent where everything else doesn't seem to matter as much. Am I understanding this world correctly?
Yes. And I think that that's the perfect point. The stakes are higher. So it is tough sometimes to like look at comp industries, although I do think aviation is one of them, which we've talked about before. I think that aviation and healthcare, they both absolutely, like, there are lives at stake really every day on the job. And so that's a good point. But I feel like even with how you presented it, I just feel like you do see the bigger picture, like you're looking at the big chessboard and you're looking at the fact that this isn't a cross section in time. Yes, in every cross section, in every moment, the patient safety and quality care is the most important thing in the world, and totally agree about like this litigiousness. And it's always like CYA, cover your butt, like that. People say that every day in the hospital. But here's what that's missing is the long-term nature of it, like the bigger picture, because I will tell you that this sense that, okay, well, like the doctors are fine. Don't worry about the doctors. The patient care just needs to be good. It's like that fallacy has been breaking down for years. I don't know a lot of doctors who are doing really quote unquote good, right? We just kind of like paint a little sheen on it and we're like, yeah, don't worry about them. They're fine. Like they're here for the patients, which is true. We are here for the patients. But I think that what we're seeing is this over time corrosion of the idea being show up to work, do your absolute best, patient safety and patient quality care above all. But exactly, kind of like neglecting these other real parts of the team, which I feel like it didn't take long for you to see right through to that. Maybe it's because you work in a genuine, like long-term team-based environment. So you might be like, oh, I wouldn't think that would last forever. But in healthcare, we're just kind of taught, again, in this revolving door model, to just kind of like hold tight and prioritize the patient forever.
I think because the relationship in a company is a longer term, as you point out, the sustainability of the employee, the fact that we can't burn out our teams, that we want them to have the best experience and the highest productivity. For example, my team's job is maniacally focused on how can we make the developer's life easier? How can we reduce friction all along their work? Where are their delays? Where can we provide them tools? Where can we provide them better training? Where can we provide them better managerial support such that they produce? And I don't see that same focus in medicine to some extent. That equation needs to change between and make the connection that better patient care comes from better doctor care, better team care, better health and sustainability of the team that takes care of this patient. That if we don't invest in taking care of the team that takes care of the patient, we will have a broken system. That connection seems to not have been made yet, or not very clear in medicine.
Yes. And the question is, and I wanted to say to your point that I have seen over my, I guess, 8 years now in ENT, I have seen a lack of physician, health lead to impacts on patient care. So like, again, that's why I say that it's this fallacy. Because like for us to even say, well, we're hobbling along and as long as the patient's fine, then this and this and this. Well, guess what? Anecdotally, like, and most people I think who've worked in a hospital system can say this, like, no, I've seen patient care suffer as a result of the breakdown at these other levels. Whether or not people are at the point where they're willing to like look that in the face or admit it, I don't know. That's for them to decide. But I would argue that we are at that point and we should call a spade a spade. What I want to ask your opinion on, because you're right about this connection that hasn't been made yet. And I will say over the years, I've been in attending for a couple of years now. And I think that like hospital systems and some of these employers are really starting to understand, okay, this is the financial impact of losing a physician, right? Like this is how much it costs to recruit and bring on and onboard and ramp up a physician. And those numbers are like in the six figures, if not more. So people are starting to see that impact. But what's so funny to me is that I have seen that language at the attending level, right? Like the fully cooked product. But in terms of all these competing interests, it's like the residency programs, the fellowships, the medical schools, like they don't have that financial incentive of, oh, this is going to be real expensive if I lose this person. So I would argue that even if we are starting to get there and to really get with the program at the attending level, it's like you may be too late because, there's so many years, sometimes decade that we've put in at the point of already becoming an attending. That's like, trying to put out the fire that already burned somebody totally up into ashes.
Exactly. And empathy is such a big part of, and the social side and the human side of medicine. And my concern is if we burn out residents, then you have people who lose all that emotional connection to their patients and the empathy with their patients. One of the metrics we track includes how we onboard new engineers into the company and their productivity metrics. How long does it take for them to be productive? What kinds of boot camps do we have? What kinds of education do we have? Because we really track all these metrics in terms of both new employees, but also ongoing. How are they doing? How are they progressing in their career? And what kinds of resources do we need to provide for them? I agree with you. The residency problem in particular is such a hard one because you have the combination of a very short time association with that particular organization. So they don't care about what happens to these people afterwards. And then you have usually many fewer residents, the staffing issue. For example, if we have someone leave, we can staff up. Or if we find that work is increasing, we can ask for new requisitions and get new headcount. I find that headcount is constrained, and so a resident really does not have time to go attend to themselves or to attend to their lives. And there's a lot of resentment if if a resident has to take some time off because the load falls on everybody else. So the staffing model seems to be also flawed in terms of how residents are staffed in programs. But this is just observations from the outside.
Yes, that's certainly true. And I can speak to it from, surgical resident standpoint. Before they can expand those positions, a program has to prove that they have X and Y and Z, case numbers that can support expansion of the program where everyone will still get adequate training and case numbers and things like that. I'm sure, similarly, they have to prove adequate volume on the medicine side. But there's this famous saying, I don't know if you've heard it, but the only thing cheaper than a mid-level is a resident. And so, I think that the staffing question, what's so funny is that I can tell you just one example. This is not like a perfect solution, but I'm saying in a pinch, the work can be done by an attending. I feel like nobody is willing to say that. I'm an attending and I'll say it because I left academia because I didn't want to perpetuate a system that does not align with my values. So I can say this as somebody who does not benefit from resident labor. I see my own consults and I do all my own documentation and often my own orders and things like that. I do have a great team and a nurse and clinic and things like that. But I will say that at the end of the day, what's really interesting and what people are jumping through all these hoops to pretend is not an option is for attendings to do this work that they are qualified to do and also being paid to do, right? Like compensated for at the end of the day. And I'll give the example of you alluded to situations where, say, a resident has a personal matter, they're going to be out for the day or the week. Okay. Yes, that's stressful because then that gets redistributed on all the other residents. There's this pressure that's okay, well, you residents who are left behind, you better absorb that work. Even though attendings running their own clinics or doing their own operative note or something, like doing a case without kind of a minion with them, those all seem like, especially quote unquote in a pinch, like not unreasonable options. It's so funny because even I am kind of pausing. I'm like, am I going to be struck down by lightning for just like saying this? I'm like looking around. I'm in my own house, like, and they shouldn't be able to get me here. And even I am kind of like, oh my gosh, like the graduate medical education mob is not going to like this, what we're talking about today. But another example that I'll use is when we take like our in-service exams every year. Unattending, I don't know how they choose this unlucky attending, but they have to carry the pager for the day. And when I was a resident, what would happen is that at 5 p.m., the residents would all get out of the test. It's a Saturday, by the way. So we show up at like 7 a.m. on a Saturday. We get out at 5 p.m. And the attending would hand a list of all the calls and pages that they got that day and give it to the junior resident on call and be like, here, this was all the work that came in today. And then that junior resident would have a really bad night.
After a full day of exams.
Mm-hmm.
I know this is to do with cost and funding and other things, but when we plan an engineering project, we assume certain staffing and certain availability of engineers, like 1080 hours a year. So we always allow for vacation, 3-4 weeks of vacation, weekends off, sickness, and any other meetings or anything else, and then only kind of schedule for actual engineering work a certain number of hours. So we are thinking about the fact that people have lives, people have other things to do. But I know that you are trying to cram as much education, as many experiences for residents as possible, so that they can be full attendings before they leave. And I wondered if you could also, work into that staffing model time for other things. And why is that not the case? Is that because of cost, or is that because otherwise residency would be 5 years if you were building all those things into account?
I think that I've seen proposed in a variety of different ways, locations, programs, specialties, things like a half day a month per resident. And that would be kind of your, almost like admin time, knowing that, acknowledging that most dentists, doctors' offices, like routine care only happens during business hours. So like you would just get this half afternoon, a half day, one afternoon protected time to do all those necessary appointments. I have seen it struck down in most of the cases, that I personally experienced or witnessed. I have heard of some places where that actually is built into scheduling and curriculum, and that's incredible. In places where I've heard of it happening successfully, it is typically bigger programs, and where you start to hear of incredible flexibility, focus on health, whether physical or mental or things like that. It's typically bigger programs where there's some redundancy. Because, for instance, when it was proposed in like my smaller program, here's the answer to your question. In terms of like, would the work be done? I mean, 100% the work would be done anyway, like, because the work would be that like that half day of clinic, like, of course it still happens either way. But guess what? Now that attending doesn't have a built-in scribe and also a person to see all the patients for them. I mean, what I think the general public also doesn't understand is how much the system is built on residents. And here's what I mean by that. So that attending who is saying, well, I cannot go a half day without residents. Guess what? They schedule patients in a way that requires a resident to be present. Like it's maybe double booked every 15 minutes. Well, guess what? That actually might be too much. Like that attending can't do it themselves. Like I agree with that, and I'm in solo practice. I could not see 2 patients every 15 minutes for a clinic day. But for capitalistic reasons, it's all scheduled that way. So then, yes, like a resident being like, you know what, it's crazy, but this tooth has rotted out and abscessed, and now I need to go care for my tooth during business hours. It puts an inordinate strain on the system. But the system is built in a way where the resident who isn't being, compensated proportionally or anything, just the resident who's doing their duty, they need to be there. And I would argue that like that half day a month of like clinic coverage or not, that's not really integral to you need to see all this pathology before you graduate. Like, I think that it feels like a huge stretch. If somebody wants to come debate me about this, like, absolutely. I would love to hear how you think that that is like a critical learning experience that will impact somebody's ability to graduate on time as a competent physician or surgeon. It's such a slippery slope, but we kind of buy into this is the way that it's been.
Yeah. Yeah. And it's built into the model, as you said. They build it to capacity, anticipating the labor of residents. I know you talked to another physician who always keeps 25% capacity open. And I thought that was such a brilliant idea. And partly our staffing model is around that.
Wow.
That you cannot, staff up, or you cannot schedule all 100% for health reasons, for redundancy reasons, for various business reasons. And that you need to always keep some spare capacity because things can happen. And I'm also curious as to why attendings don't take the calls when someone is not there. Is that because they're also overscheduled, and so there is no spare capacity from their perspective as well to pinch hit when a resident is not there?
I think they're protecting the status quo. Which I'm going to I would go so far as to use the term learned helplessness.
Yeah.
And shout out to every other person who's ever worked with an attending who doesn't know how to place an order, doesn't know how to place an H&P, pre-op. Learned helplessness is very real. There are expectations in this archaic system, but that further contributes to like the resident sense of it's very true. The trainee doesn't want to dump work on their coworkers because just guess what? Like, let's give the benefit of the doubt. Nobody likes to dump work on their coworkers. So
correct.
Just assume that that's not what they're trying to do. But yet there are, attendings are the line of backup and like redundancy available. But they have a lot more power than the other players do. So they can kind of, almost rig the game. Because when I talk about, double, triple booking a clinic, that doesn't even start to talk about triple booking ORs. I've run a third OR before for someone. And that's something that occasionally hits mainstream media and news, or, there's a plot about it on The Resident, the TV show. And people are horrified. They're like, what? 3 ORs with 1 attending? Like, who's in the room? And it's like, yeah, people find it unsavory to learn the truth and to know some of what's really going on. But I guess my question for you, as we look at residency, and I think that we've like pretty appropriately evaluated, like, so these are some of the reasons why the system has been this way. And here's why people at the top are not incentivized to change this system, which honestly makes a lot of money for someone. So who and what and how can we help those residents? Like, yes, acknowledging that usually by the attending level, there are people in society who are like, you know what? An attending is actually worth some money. Like, we should protect those people and we need to acknowledge their value. But it's like, how can we help everyone up until that point where maybe there isn't someone in the same way looking out for the value and the long-term health?
I've seen the one of the episodes that you did, I think, residents creating a union was one way of creating some bargaining power to change the culture. And historically, if you see the Industrial Revolution and from early days to now, the reason why workplaces are so much better today is because there were people who fought all along the way for, whether it was health conditions or the lighting conditions or better, working conditions, hours, etc. And so I think that definitely helps. I was also looking at, I was asking AI, what would you do to change residency? Well, and AI had some really interesting answers for me, such as advocacy with, AMA and the body that does residency. I'm searching for my notes here in terms of some of the answers from
that
AI.
is interesting.
Yeah.
Oh my gosh. Well, and I'd never thought of that. But I mean, I think advocacy is great. I think AMA and ACGME, I've served with both institutions, attended conferences. I feel like institutions are slow and also institutions are old. Neither one of those groups is inundated with the younger, less powerful members who are vulnerable, who we're talking about here. So I do think advocacy has its limits. And so I'd love to know what other stuff AI came up with.
But to your point about that they are legacy institutions and haven't changed, I think the face of leadership has to change in those institutions if policy needs to change. And it has to reflect what the medical body is looking like today. It's more than 50% women. It is more and more people of color. And once you have, people in AMA, AC, GME, HRSA, Centers for Medicine and Medicaid, et cetera, AAMC change, then I think policy can change. A couple of other thoughts I think AI had were around the use of modeling and I forget, simulation in training. Can that be used? And I'm trying to also look for other answers that I received, which I thought were fantastic. Certainly, yeah.
Oh, sorry. I just wanted to say simulations. I think that's a great point because, where the technology is available, like what a great way to give trainees, young docs exposure without requiring them to be at the hospital, 120 hours a week to be exposed to X, Y, and Z. It's like, well, it's 2025 now. And so the question is, how can we more efficiently teach? Like, we don't have to do the old school method, which is sit around, live in the hospital, and try to see all interesting pathology that comes in. Like, there's ways to use tech.
Precisely. And you made the analogy that it's like, air travel. And it's very much like that.
Yes.
And in training pilots, there's a huge amount of simulation that's done before they even kind of, are let loose on actual planes. And I think simulation was one big area that it suggested. Curriculum changes, mentorship programs, mental health support, work hour reforms, wellness programs, interdisciplinary teams, feedback and evaluation from residents, and regularly paying attention to that. But frankly, the incentive systems need to incent program directors and attendings to actually teach, manage, lead, and support their residents. If they're not measured for that, they're only measured for the number of patients they see, it's going to continue to be the way it is.
Yes, that's the $1 million question to me, because it's just like, what will that look like for those incentives to change? And also, where is that funding going to come from? I do think that tech obviously benefits from like great financial support.
Right.
It's not like this question of like, well, you're describing something that will have a long-term payoff. Where is that money going to come from? I do think that for some reason, even though healthcare is like a bajillion dollar industry, somehow that's a question of like, where would this money come from?
That's correct. The other challenge is the demand is infinite for healthcare, and a lot of the demand cannot pay for their healthcare. So I think the industry has to pay for all that, and so I suspect that pays into the equation. You're exactly right. In tech, there is money, and I am, my compensation, I'm judged on how my team thinks of me, how my team feels that I'm leading them and creating a safe environment for them to succeed and work, and the productivity of my team. It is a reflection on me as a manager. So I get a survey every month called Connections, which shares with me what the temperature of my team is, whether they think I'm a good leader, whether they feel I'm being inclusive, what their job satisfaction is at that current time. And it's a huge part of, how I'm looked at as a manager.
Is that anonymous?
It is anonymous. It is anonymous. So I do not know who on my team. Yeah. And I take it very seriously.
Well, that's incredible. I think that's wonderful that people like you are in these positions of leadership, because I honestly, I believe you. I believe you that you take it seriously, and I don't worry for your employees where I'm like, oh, she's going to retaliate against you. Best wishes if you report cool numbers on the survey. Those are all very real concerns on our healthcare side. We have the ACGME annual reporting survey, especially in a smaller program. Guess what? The leadership feels like they can guess which squeaky wheels gave lower numbers, and they will retaliate. They'll be pretty vocal about that often. I think that that's incredible that, but it would be scary for a lot of people in healthcare, I think, if the way that they treat other people in the hospital even was tied to their compensation. We'd suddenly start to probably see some very different numbers for how physicians are paid. And I think that I really like all the ideas that you've put forth. I think that every single one of these should just be investigated and trialed and things like that. Although again, it's this question of but how can we get buy-in to trial these different things? Another example that I've heard of that really augments what you're talking about, I think it supplements it from the other end, is the thought about having transparent rankings or feedbacks about cultures of residency programs.
Yes.
That's an idea I've heard it pitched before. It's come under enormous fire when it's been pitched, but there's things like Rate My Professor. We'll get more into this, in 2025 with a couple different episodes. But I mean, yeah, it's why couldn't that exist? And I will say, because I can play devil's advocate on this, one of the reasons why even a Rate My Professors, Rate My Program type of thing wouldn't work that well is because guess what? Competitive specialties, they're going to have a line of applicants out the door either way. Sure, that person may rank a place higher that is less toxic, but at the end of the day, the match system inherently sets everybody up for the powerless, sometimes deranged dynamics of residency training.
It's interesting if you can make it safe for institutions and attendings that the survey is more a learning tool and that it's a tool for them to improve the program, improve how they're leading. I look at it that way, and it's not punitive to me. And so I feel it makes me a better leader. It raises the bar for me. And so if you make it less punitive, I think then people tend to use that feedback and hopefully improve the program rather than punish, the person who spoke.
And I love that, but I just wonder, and so I love that. Agreed. If we can make it not punitive, but then that other missing piece, I would think the equation should be not punitive plus tied to some kind of financial incentive.
Yes.
Because what I will say, and this is a shout out to the incredible attendings and kind of teachers out there, they exist, sorry if I come off as a sourpuss sometimes, like I said, it's nosebleed season. And so sometimes I sound like a sourpuss. But here's the thing is that I have known incredible attendings and teachers who they go above and beyond for their trainees to try to make it inhabitable and educational in the hospital. And what's brutal, especially as I quote unquote have grown up. It's funny because when you're a resident, attendings are just like parents and you're like, oh, you don't do anything other than come here and like do your job. You know, it's so funny. You don't think of them as being like this 3-dimensional person. But what I have a real appreciation for, just getting to know some people better, is how much true passion and care and time pours into that for them. And guess what? Are they compensated? Like, is their compensation in any way tied to that? Not only is it not tied, but sometimes the time they spend on like resident development, wellness, innovation, trying to like take feedback, think, what can we do that's new or that will benefit my program? It quite literally can take away from their RVUs, which can literally decrease compensation. So make that make sense. I would, some of these people are decentivized.
And you hit it on the nail. It's not celebrating the good behaviors and the kind of behaviors you want to see. And instead it's, punishing them. So there's no incentive to be a good attending, to kind of be a good manager, to be a good leader. And it feels like a lot of incentives need to be realigned in the system.
Well, I mean, it's such a joy to talk with you. And I think that we have like a lot of good framework for like what we're seeing between what the system is right now and maybe where we all want it to be. So I really appreciate you coming on to kick around these ideas with me. And I mean, honestly, I'd love to continue this conversation. Like, I feel like you and I have a real kind of like endless hunger for making this better and like continuing the conversation.
I agree. It's such a pleasure to talk to you. And this is near and dear to my heart as well. Partly because of my daughter, but partly because it's such a fascinating supply chain and industry, and taking, some of the lessons learned and taking it to another industry is fascinating to me.
Yes, and there's absolutely a lot that we can learn from you in this regard. Before we sign off, I would love to ask you, do you believe in karma?
I love that question so much, Frances May. I've heard you ask so many times.
Mm-hmm.
I grew up Hindu and I'm a practicing Hindu. So the concept of karma is very integral to our culture. It believes in, you will come back in the next life based on how you performed in this life. So I don't believe in an afterlife for some reason, my technology background maybe, but I do believe that people will reap what they sow, that if you are a good human being and put forth good in life, good comes back to you. So there's a real important reason to be a good human being.
That's beautiful. You gave me goosebumps a little bit, and I certainly, I tend to agree with you. Nithya, truly, it's been such a pleasure talking with you on Promising Young Surgeon. Your inspirational life and your advice will no doubt resonate with a lot of our listeners out there. Where can they find and connect with you online?
The best place to connect with me online is on LinkedIn at Nithya Ruff. And I welcome, further conversations on this topic.
Wonderful. And absolutely. Well, we can link to that to make it easier for our listeners to find you. Follow me on Instagram at francismay.md and at Rethinking Residency. Visit my website, rethinkingresidency.com, to learn more about resident physician stories and ways that residents can most effectively navigate the game of residency. Thank you for tuning in to this episode of Promising Young Surgeon. If you enjoyed the episode, please subscribe, rate, and leave us a review. Until next time, keep pushing boundaries, innovating, and advancing in your journey. If you'd like to submit any questions for future episodes, email me at pys@heyinfluent.com.